On behalf of the Dolan Lecture Committee and the Dolan family, I am honored to welcome you to the 12th Annual Dolan Lecture. Bill Dolan passed away on June 4th of this year. His passing left a huge void in the hospital community and the community at large. This remarkable man was born in 1913 in Rhode Island, a part of our country that did not look too favorably on people who could not trace their roots to the Mayflower. Overt and covert prejudice was on a daily menu for many citizens of New England. We've all heard and read about the notices, help wanted, Irish and Italians need not apply. In the parlance of the day, the Dolans lived on the wrong side of the tracks. With the example set by his parents, Bill Dolan worked hard academically and athletically while helping his dad in the family business, a general store where they also brokered insurance. People from all over the area came to see Dolan perform in 4 sports. He was a superstar in the community. People from both sides of the tracks came to see him play. Dolan and others like him didn't move to the opposite side of the tracks, which people sometimes aspire to. They just moved the tracks. It would not be a stretch of the imagination for those who knew Bill Dolan to know that on occasions in discussions with his peers, he might have referred to those Yankee bastards. Bill's hard work academically at URI, where he matriculated from high school, allowed him to continue to reach his goal. He was an all-star in 4 sports. He's in the University of Rhode Island Hall of Fame. He had the distinction of scoring 4 touchdowns in a game as a pulling guard. Now, if you want to know what a pulling guard was, Don Nolan is here after the lecture. He'll be happy to tell you what that is. He went on to Georgetown Medical School, and after finishing his training at Georgetown, he served in the Army Medical Corps with distinction in the European theater. In addition to helping to set up field hospitals as the Allies moved through France and Germany, he also gathered forensic evidence for the future Nuremberg trials. Shortly after returning from Europe in 1947, Bill Dolan became the first chief of pathology at this hospital, which had opened just 3 years earlier. Within a year, he spearheaded a move to affiliate with Georgetown Medical School, which would mean that Arlington would become a teaching hospital with 24-hour house staff. Today, we have residency training in 5 specialties. This is another example of Dolan's commitment to education, medical education. The attempt to join with Georgetown had some anxious moments. There were whispers that the Pope was going to take over Arlington Hospital. They're going to change the name of it to St. Arlington's. My goodness, there were railroad tracks in Arlington. But Dolan had some experience in that area, so he just pushed ahead and demonstrated the benefits to all and pushed a little harder, and it happened. Dolan had moved a second set of tracks, this time in Virginia. I must say, forgive me for calling him Dolan. That's all he ever called himself. It was always Dolan says this or Dolan's going to do this. So it was his choice. Please forgive me for a moment of personal recollection. In 1973, I just finished serving 8 years on the Arlington County Board, and I was going to spend my time off working on my golf game. Bill asked me to join the Arlington Hospital Board. Quote, they only meet quarterly, and there isn't much work to it. A classic example of an Irishman conning another Irishman. I went to my first meeting and found out that the hospital was on a cash-only basis with the bread man, the milkman, and every man. Bill Dolan and Tom McWilliams, chief of radiology, had not accepted their compensation for their labors for a long time in order to help keep the hospital doors open. They were both raising families, paying mortgages, and working 80 hours a week. We were fortunate after that to get some very energetic, talented people in the community involved, and things turned around. In 1981, the Hazel family came to see us because they wanted to do something to honor their dad, Dr. John Hazel, who was the first general surgeon to perform a procedure in the New Arlington Hospital. A place for the students, residents, and the community of physicians to meet and learn, said Bill Dolan. In his usual taciturn manner, with great help from the Hazel family and the community, to the tune of $800,000, this conference center was opened in 1982, Dolan on Education. 13 years ago, a group of friends and admirers of Bill Dolan decided to do something to honor him. Many different suggestions were proposed. The one Bill liked best was an annual lecture series to bring the best and the brightest clinicians and researchers from anywhere in the world. And here we are 12 years later, Dolan on Education. We on the committee are determined to continue this series in perpetuity. People who donated the funds for this lecture series donated them specifically for that purpose, and we want it to continue. It's my distinct pleasure to introduce Patrick Correnti, who is Dr. Patrick Correnti, who is on the Dolan Lecture Committee. Patrick?
Thanks. It is a pleasure tonight to welcome back Dr. John Gerich to the Arlington Hospital in the Washington, D.C. area. Dr. Gerich was born in New Jersey, went to undergraduate school at Cornell University, and then came down to Georgetown University and the Arlington Hospital to do his internship residency in medical school. Dr. Gerich then went on to University of California in San Francisco to do a fellowship in endocrine and metabolic disorders. Dr. Gerich has a distinguished career which includes over 40 publications on diabetes literature, and he has honors such as the American Diabetic Association's National Chairman for Research. He's currently a professor of medicine at the University of Rochester School of Medicine, and he's involved with administration and student research projects. The Dolan Lecture Committee chose diabetes as its topic this year, and with the help of Dr. Robert Santangelo, we selected Dr. Gerich as our speaker based on his distinguished and outstanding career. Of note, Dr. Gerich is the first Arlington Hospital and Georgetown University graduate to give the Dolan Lecture since its inception in 1987. I'm honored to introduce Dr. Gerich to discuss the new frontiers of pathogenesis and treatment of type 2 diabetes. Thank you very much.
He's going to change the cassette.
Well, it's a great pleasure to be here. I'm very honored to be associated with the Dolan Lecture. I'm also very thrilled because I trained at Arlington Hospital. I rotated through here as a medical student in the emergency room, and then Dr. Dolan teach me how to do histories and physicals. And in the back, another mentor of mine, Dr. Santangelo, he was a resident when I was an intern. So it's a great thrill for me to come back here. I've been interested in diabetes for over 30 years. Okay. And it's been a very exciting area that thrills me every day. I remember when my children were about 7 years old, they said, "Dad, what do you do at the hospital?" And I said, well, I work on diabetes. And they said, well, you've been working on that a long time. Haven't you finished yet? Well, tonight what I want to do is to review with you some new developments in our concepts of the pathogenesis of type 2 diabetes. And since I believe there's some lay people in the audience, I'm going to try to start off at square one. Now, diabetes is actually a syndrome. It's a group of disorders that are characterized by hyperglycemia involving carbohydrate, lipid, and protein homeostasis. And it's due to both genetic and environmental defects. And these defects affect insulin secretion and insulin action. And acutely, they can cause diabetic ketoacidosis and hyperosmolar coma, and chronically, the long-term complications: retinopathy, nephropathy, neuropathy, and premature atherosclerosis. Now, recently, the American Diabetes Association has reclassified diabetes into different subtypes. Type 1, which represents, as you'll see, about 10% of all people who have diabetes, is an autoimmune disorder of unknown etiology. The cells that make insulin in the body are completely destroyed, and patients are dependent upon insulin for life. So this is why it was formerly called insulin-dependent diabetes. The other type is called type 2 diabetes, and this is a polygenic disorder due to various combinations of impaired insulin secretion and insulin resistance. And this was formerly called non-insulin dependent diabetes or adult onset diabetes. Now, many patients ultimately require insulin treatment to get good metabolic control, but strictly speaking, they're not dependent upon it for life. And then we have other, type 3, which comprises many secondary types of diabetes and represents a small percentage. About 16 million people in the United States have diabetes. And as you can see, roughly 90 to 95% of these have type 2 diabetes. So type 2 diabetes is really the diabetes problem. And just to give you an idea of the magnitude of this, it's been estimated that 1 out of every 7 healthcare dollar is spent on someone with diabetes. And if you add up all the direct and indirect costs, it comes to over $100 billion a year. Now, most of those costs are not related to office visits to diabetologists such as myself, but in the treatment of the chronic complications. And people with type 2 diabetes, if you correct for duration, develop the complications with the same frequency as people with type 1 diabetes. This slide shows the results of an epidemiologic survey comparing the prevalence rates of the complications in people with type 2 and type 1 diabetes. And I think you can appreciate that for retinopathy, neuropathy, and renal impairment, the prevalence rates are about the same. And in fact, if you look at macrovascular disease, that's about threefold more common in people with type 2 diabetes. So the bottom line is that type 2 diabetes is just as serious a disorder as type 1 diabetes. Now, we have a little bit of bad news. As you know, the prevalence of diabetes increases as a function of age. And this data is taken from the NHANES study, a national health survey in the United States. And it's been found that the prevalence rates increases so that people over the age of 65, about 18% of those have type 2 diabetes. And our population is aging. Back in 1986, 11% were over the age of 65. By the year 2020, that's going to double. So all things being equal, the problem of diabetes will double. Now, that's the bad news. The good news is that now we know beyond doubt that good control can prevent the complications of diabetes from starting and slow their progression. We've had marvelous advances over the past 10 years in our knowledge about glycemic control and complications, and pathophysiology, which I'm going to emphasize in this talk, and the introduction of numerous new treatment modalities that help us get better metabolic control in a greater proportion of our patients. This slide just lists the agents that have come on the market in the past 5 years. In terms of control and complications, last year the results of the United Kingdom prospective diabetes study were reported. In this study, 5,000 newly diagnosed patients with type 2 diabetes were randomized to conventional loose control or strict control with sulfonylurea drugs, which stimulate insulin release, insulin itself, or metformin. And over the course of 15 years, the hemoglobin A1C levels, which is a way that we measure the average blood glucose level in a diabetic patient over the last 3 months, averaged about 8% in the control group. Now, to put this into perspective, the American Diabetes Association says that the goal of therapy is to normalize the hemoglobin A1C, get it down to 6.1. Below 7 is considered the target. If the hemoglobin A1C is above 8, action is recommended to lower that. So the control group was just a little bit above that. The intensively treated group over this 15-year period averaged about 7%. So we only had a 1% difference in hemoglobin A1C. The average hemoglobin A1C in type 2 patients in this country is almost 9%. Now, what was the result of this 1% difference in metabolic control? Well, any diabetes-related complication, the risk of developing that was reduced 12%. Myocardial infarction, reduced 16%. Did not quite make statistical significance. But for years, we've been worried that sulfonylureas might be cardiotoxic, that insulin might be atherogenic. This study put that to rest. Microvascular complications, the retinopathy, the nephropathy, reduced 25% by just that 1% difference. So now we know for sure that in type 2 patients, just as was shown in type 1 patients with the diabetes control and complications study, that good control prevents complications. So now I'm going to shift and talk about pathophysiology. Why do people get diabetes, and why do their blood sugars go up? For many years, it's been controversial about which is the most important genetic factor. Is it impaired insulin secretion, or is it insulin resistance? Another area of controversy was, why do the blood sugars get high? Is it because the body overproduces glucose, or because it doesn't use enough? Now, until quite recently, the prevalent view was that insulin resistance was the primary genetic factor. And let me just make an aside here. Type 2 diabetes is a much more genetic disease than type 1 diabetes. It's due to many genes which have yet to be identified. If you have a monozygotic twin who has type 2 diabetes, you have about an 85% chance of getting diabetes sometime during your life. If you have a identical twin who has type 1 diabetes, your risk is only 50% of getting type 1 diabetes. Now, according to this view, people are born with insulin resistance, but they maintain normal glucose tolerance because the pancreas secretes extra amounts of insulin to compensate. Some people in this pre-diabetic state develop impaired glucose tolerance. Now, in this condition, you have normal fasting glucose levels, but just high glucose levels after meals. And it's thought that this occurred because of worsening of the insulin resistance without an appropriate increase in insulin release. And then some of these people with impaired glucose tolerance develop overt diabetes. And this was thought to be due to exhaustion of the pancreatic beta cell. Years and years of secreting all this extra insulin, it finally poops out. Now, one of the main pieces of evidence in support of this theory has been the relationship between the insulin levels 2 hours into a glucose tolerance test and the 2-hour plasma glucose level. In every population where this has been studied, the same relationship has been found. As glucose tolerance deteriorates, the circulating insulin levels go up to a certain point, and then they fall off. So this data has been interpreted to indicate that early on here, the body is secreting more than a normal amount of insulin. So insulin secretion can't be the problem. If this extra insulin can't maintain normal glucose tolerance, then the initial problem must be insulin resistance. Now, this slide shows the individual curves presented in the previous slide. This is data from my laboratory. This represents about 400 oral glucose tolerance tests. And here we have the insulin response of people with normal glucose tolerance. You see there's a very early rise in the insulin levels, and then it comes back down to normal. It does that because the circulating glucose levels come back down. The major stimulus for insulin secretion is the plasma glucose level. Now here we have the insulin secretion of people with impaired glucose tolerance. You see, they have an impairment in early insulin release. It's lower than normal, even though the stimulus, the plasma glucose levels, are higher than normal. And then later on, they have late hyperinsulinemia. And this could simply be due to the fact that there's a greater stimulus for insulin secretion out here. Here are the insulin responses of people with diabetes. They have even worse early insulin release and still some late hyperinsulinemia. Now, we postulated from this data that it was a defect in early insulin release that was the first detectable defect. And this slide just shows the relationship between that early insulin release and the 2-hour plasma glucose level compared to the 2-hour plasma insulin level. As glucose tolerance deteriorates, very early on, you can see a decrease in that early insulin release. Now, this is not a discovery that we made. The first observation of this was back in 1961 by Burson and Yalow, who won the Nobel Prize for their discovery of the method of the radioimmunoassay method. And in their classic paper on insulin responses in people with different degrees of glucose tolerance, they found the same thing. They divided their groups here into people with normal glucose tolerance, impaired glucose tolerance, and diabetics with high fasting glucose levels and close to normal glucose levels. And what they found is what I just showed you. Here are the 2-hour insulin levels, and you see they rise and then fall as the glucose tolerance deteriorates. But here's the early insulin response. That just progressively decreases. And there's direct experimental evidence that these early insulin responses are essential to maintain normal glucose tolerance. In this slide and the next slide are the results of experiments where the investigators took normal volunteers with normal glucose tolerance, gave them glucose tolerance tests on 2 occasions. On one occasion, they infused a hormone called somatostatin, just for 30 minutes, to block the early insulin release, to simulate the insulin response of what you see in people with impaired glucose tolerance. So this shows the normal insulin response and the impairment in that early insulin response. Oops, I put them out of order. Okay, these are the insulin responses. So the impairment in the early insulin response. And you see if you impair that early insulin response, it leads to late hyperinsulinemia. insulinemia. This has nothing to do with insulin resistance. And here are the glucose levels. This delay in early insulin release converts people with normal glucose tolerance into impaired glucose tolerance. So we know this early insulin response is important. Many investigators have tried to see which is the first defect to become evident, because presumably the first defect to become evident is the genetic one. Now, a few years ago in a paper published in JAMA, we looked at 50 people with normal glucose tolerance, but who had a first-degree relative with type 2 diabetes. And we matched each one for one, a man with a man, a woman with a woman, with 50 people with no family history of diabetes and normal glucose tolerance. And this slide just shows the glucose tolerance test in the two groups. They're identical. You could not distinguish them. Then we did glucose clamp experiments to test their beta cell function and their insulin sensitivity. What you do with this test is to raise the plasma glucose level by infusing glucose to 180 milligrams %. And this, of course, stimulates insulin secretion. And here I think you can appreciate that the people who had relatives with type 2 diabetes had a lower early insulin response and an early late insulin response. Now you can also look at insulin sensitivity with this method, because the amount of glucose that you have to infuse to keep the blood glucose at 180 is dependent on two factors: the insulin released and how the body responds to that insulin. And so you can calculate an insulin sensitivity index by dividing the amount of glucose that has to be infused by the circulating insulin level. And as you can see here, it was slightly greater than normal in the people who had relatives with type 2 diabetes. So instead of it being reduced, it was slightly increased. So this data provides evidence that the first detectable defect in people who might be pre-diabetic is an impairment in beta cell function. The most, I think the strongest data are the results of studies that have been looked at in monozygotic twins. This is a study from Scandinavia where they took the monozygotic twin of someone who had already developed diabetes. Now, some of these twins had impaired glucose tolerance, but others had normal glucose tolerance. And they looked at their insulin sensitivity by methods similar to the one I just discussed, and their beta cell function. And when they looked at beta cell function, the people who had still normal glucose tolerance had a reduction in beta cell function. Now remember, I mentioned earlier that if you're a monozygotic twin of someone with type 2 diabetes, you have about an 85% chance of getting type 2 diabetes at some time in the future. So these are truly pre-diabetic individuals. Now if we look at their insulin sensitivity, it was not significantly reduced. So the first detectable defect was one on beta cell function. Now, another argument against the insulin resistance being genetic is that it's reversible. There are several studies in the literature to show that simply by weight loss in obese people with type 2 diabetes, you can make the insulin resistance go completely away. And I want to show you one of these studies. This was done by Dr. Beck Nielsen in 1984. And he put obese people with type 2 diabetes on a weight-reducing diet for a year. And they lost weight, and their fasting blood glucose levels came down into the near normal range. He looked at their insulin sensitivity by looking at the percent drop in their glucose levels after an injection of insulin. So before weight loss, you see it was here. After weight loss, it was here. So the greater the percentage drop to a standard dose of insulin, the more sensitive the people were. And I don't know whether you can appreciate it, but there are squares here representing the responses in normal volunteers. So the insulin resistance in these patients with type 2 diabetes completely went away. Now, he also looked at beta cell function by an injection intravenously of glucose. And here's the response of the normal volunteers. Here's the response of the patients before weight loss. You see there's no early insulin response. Here's the response after weight loss. So there was some improvement, but it certainly did not normalize. And this probably explains why the people remained diabetic when their insulin resistance was completely reversed. So now, over the past few years, people have been drifting back to impaired insulin secretion as being the primary genetic defect. In the pre-diabetic state, it's thought that there is a subclinical impairment in beta cell function. Some of these people with this genetic defect develop impaired glucose tolerance because of deterioration of beta cell function over time, or because of the superimposition of insulin resistance on a beta cell that cannot fully compensate. And we have a very good example of this. It's called gestational diabetes. During the 3rd trimester of pregnancy, all women become insulin resistant. Now, some women develop diabetes. And if you measure their insulin resistance and compare it to the ladies who do not become diabetic, it's not different. The difference is the ladies who do not become diabetic have much higher insulin levels than those that do. They can compensate for the insulin resistance. And similar mechanisms are believed to be involved in the deterioration from impaired glucose tolerance to overt diabetes. So now let's talk about whether the high blood glucose levels in people with type 2 diabetes is due to overproduction or underutilization. And first we'll talk about postprandial hyperglycemia, since that is the earliest abnormality that we see. Now, in this and the next few slides are data from an article we published in the New England Journal a few years ago. We studied non-obese and obese people with impaired glucose tolerance and compared their results to non-obese and obese people with normal glucose tolerance. And as you can see, the people with impaired glucose tolerance had near normal fasting glucose levels. Their hyperglycemia was postprandial. They had a delay in their early insulin release, late hyperinsulinemia, and they also had an impaired suppression of glucagon secretion. Now, glucagon is a hormone made in the alpha cells of the pancreas, and it has opposite effects on glucose production to insulin. Now, we used a double isotope technique. One isotope of glucose was put in the glucose drink, and another isotope was infused intravenously. So with the isotope in the drink, we could measure the rate of appearance of the glucose that was ingested into the systemic circulation. And I think you can appreciate here there was no difference between the people who had normal glucose tolerance or impaired glucose tolerance. The big difference was in endogenous glucose production. The people with impaired glucose tolerance did not turn off their endogenous production of glucose as did the people with normal glucose tolerance. After we eat, one of the main purposes of the carbohydrate in there is to replenish hepatic glycogen stores. And it doesn't make too much sense for the liver to keep putting out glucose when it wants to accumulate. Now, if you add up this amount of glucose entering the circulation and this amount, you see that more than a normal amount of glucose enters the circulation during this postprandial period. Now, you can figure out what must have happened to glucose utilization. These people start off at a normal glucose level, end up at a normal glucose level. In between, they put more than a normal amount of glucose in the circulation. Well, to get back to a normal glucose level, therefore, they must remove more than a normal amount of glucose from the circulation. And when we measured it, that's exactly what we found. Now, we also had a catheter in a deep forearm vein, so we could measure glucose uptake by forearm muscle. And that was not reduced in the people with impaired glucose tolerance. Now, I'm not going to say it's totally normal. You have to remember, these people had the late hyperinsulinemia. They had higher glucose levels. You would expect them to take up more glucose in muscle, but they didn't. So they had inefficient muscle glucose uptake. But in an absolute sense, it was not reduced, whereas glucose production was increased. And the same thing happens, but to a greater extent, in people with type 2 diabetes. Their oral glucose appearance in the circulation is pretty much normal, but they barely at all turn off their own body's production of glucose. So they have a marked increase in the total amount of glucose appearing in the circulation, and they also have a marked increase in the amount of glucose leaving the circulation. Now, not all of this extra glucose is taken up by tissues. A lot is excreted in the urine. But even subtracting that glucose that appears in the urine out, the body's utilization of glucose is not reduced. So the main problem with postprandial hyperglycemia is not turning off one's own production of glucose. Now, what about the fasting state? Well, pretty much every study that's looked at this has found the same thing. This happens to be data from my laboratory, which we published in the New England Journal about, it must be 8 years now. But pretty much what everyone's found is as the plasma glucose level increases, so do rates of glucose production. Now, these studies are done after an overnight fast in what's called a steady state. The blood glucose levels are constant. So what this means is the rate at which glucose enters the circulation must equal the rate at which it leaves the circulation. Otherwise, the glucose levels would be changing. So when you calculate glucose disposal, you get the same numbers as glucose production. So as hyperglycemia gets worse, glucose disposal actually increases. Now again, once you get over 10 millimolar, 180 milligrams per cent, some of that glucose appears in the urine. It doesn't represent tissue glucose uptake. But I think you can appreciate that even below that, glucose disposal is increased. So type 2 diabetes is a disorder of overproduction of glucose by the body, not underutilization. Now, I've discussed impaired insulin secretion, mentioned a little bit about inappropriate suppression of glucagon secretion. Insulin resistance is also involved. And we believe that the main causes of the insulin resistance is obesity, especially central obesity or intra-abdominal accumulation of fat. Physical inactivity is another main cause, and glucose toxicity, which I'll come back to in a little while. The adverse effects of hyperglycemia per se. Now, how does obesity cause insulin resistance? Well, we're not 100% sure, but the larger fat mass you have, the more you will release fatty acids into the circulation, and the higher the circulating fatty acids will be. And you'll get an increase in fat oxidation. Now, in the liver, this increased fat oxidation will stimulate gluconeogenesis, and so you'll have an increase in hepatic glucose production. In muscle, you will have competition between fatty acids and glucose for oxidation. So you'll have this inefficient glucose uptake. You need a higher glucose level to get the same glucose uptake. And then you also have toxicity on the pancreas. There's evidence recently from animal studies that if you elevate their circulating free fatty acid levels, you impair the ability of the pancreas to secrete insulin. Now, there's another potential way that obesity may lead to insulin resistance. Fat cells secrete a substance called tumor necrosis factor alpha, and that's been shown in animal studies to cause insulin resistance. In fact, a new class of drugs that have recently become available called the thiazolidine diones, which are insulin sensitizers. One of the ways that they're believed to work is to reduce the production of tumor necrosis factor alpha from fat cells. Now, insulin resistance may not be the main genetic factor, but what's its relative role in causing hyperglycemia relative to impaired insulin secretion? Well, we've looked at this from a statistical point of view. We've done studies in about 320 subjects, some with normal glucose tolerance, some with impaired glucose tolerance, some with overt type 2 diabetes, who are well matched for age and degree of obesity. We gave them oral glucose tolerance tests, and we also, via the method I showed you earlier, the hyperglycemic clamp studies, measured their early insulin release, their late insulin release, and their insulin sensitivity. And as you might expect, people with impaired glucose tolerance had an impairment of their insulin secretion, and they also had insulin resistance at this time. And people with type 2 diabetes had worse impairment. And we asked what percent variation in the fasting hyperglycemia and the postprandial hyperglycemia could be explained by variations in insulin secretion and insulin sensitivity. And you can look at this with multivariate linear regression. And when we did that, the correlation coefficients for impaired insulin secretion and insulin sensitivity explained about the same degree of variation of the fasting glucose levels and the same degree of variation for the 2-hour plasma glucose levels. So what this data suggests is that both are about equally important in determining degree of glucose intolerance and hyperglycemia. And certainly we know how very effective reducing insulin resistance is. I just want to show you what happens simply with weight reduction in obese patients with type 2 diabetes. Now this slide shows data on a study where 10 people with type 2 diabetes who were obese, their weight was about 220 pounds, were put on a very low calorie diet for about a month. And they lost about 20 pounds on this regimen. They were still overweight since they didn't grow any taller. Now, their fasting plasma glucose levels decreased from 291 down to 107. That's a normal fasting glucose level. And this decrease, their circulating insulin levels decreased by 50%. So simple weight loss led to a marked improvement in insulin sensitivity and a marked improvement in glycemic control. So this slide tries to summarize my concept of the pathogenesis of type 2 diabetes as we understand it today. Initially, we have a genetic defect in the pancreas leading to impaired insulin release in response to increases in plasma glucose levels. This defect, coupled with insulin resistance, that's there because of obesity, usually, maybe a little physical inactivity, early on leads to just postprandial hyperglycemia, impaired glucose tolerance. And that, as I showed you, is due to a failure to turn off glucose production. Later on, as beta cell function deteriorates, you get frank overproduction of glucose, and now you have fasting and postprandial hyperglycemia. Now, this hyperglycemia has many adverse metabolic effects. Number one, it reduces the number of glucose transporters in cells. Well, this is going to lead to more insulin resistance. Number 2, the late hyperinsulinemia leads to a reduction in the number of insulin receptors on cells. Well, that's going to lead to more insulin resistance. Finally, you've got post-receptor defects in insulin action that occur as a result of hyperglycemia and maybe hyperinsulinemia. So even when insulin binds to the reduced number of receptors, the signal that's generated doesn't work properly. So more insulin resistance. And then, to make matters worse, this chronic hyperglycemia further impairs insulin secretion. However we improve glycemic control in our patients, either by diet or one of the pills or even giving insulin itself, you'll get an improvement in beta cell function and you'll get a reduction in insulin resistance. So these are both targets of our pharmacologic and non-pharmacologic intervention for people with type 2 diabetes. And earlier I showed you a list of new drugs that have come on the market in the past 5 years. Well, I'm glad to say that there are new treatments currently in development. There are non-sulfonylurea drugs that stimulate insulin secretion that are in development. These are ones that produce a preferential increase in that early insulin response. We have non-thiazolidinedione insulin sensitizers in development, antagonists to glucagon, short-acting insulin analogs, in addition to the Lispro insulin that came on the market recently. There's a long-acting insulin analog that is going to the FDA. This will give a nice flat insulin profile, like the old mixed beef pork insulin, and will mimic the background that one sees when people use a pump to treat. I'm sure you've read the newspapers and know that inhaled insulin is now undergoing clinical trials, and that this may alleviate the need for prandial shots of insulin in people with type 1 diabetes and maybe encourage more people with type 2 diabetes to take insulin more frequently. And finally, and maybe most importantly, are the development of non-invasive glucose sensors. Most of my patients don't mind taking multiple shots of insulin with these new pens that are out now. Very convenient. They don't have to carry syringes and bottles, and the pen needles are much smaller than the ones on syringes. But they hate to prick their finger and check their blood sugar. And they're supposed to do this before each meal, so that with that number they can decide how much insulin to take. Well, and of course, they're charged per strip. So it costs them every time they check their blood sugar. With these non-invasive glucose sensors, and there are different varieties undergoing testing, they're painless. And it costs no more to check your blood sugar 100 times than one time. And I think the more we get people to check their blood sugars, the more control they will have over their disease, the more fine-tuning they'll be able to do, the more likely they are to get hemoglobin A1Cs below 7% and not develop any complications, or if they have, to slow their progression. But I'll stop here. I'd like to thank you for your attention, and I'll be happy to try and answer any questions that you may have. Thank you. Yes, a question there.
Is there any future for islet cell transplants or pancreatic transplants?
Okay, the question... The question relates to how are islet cell transplants and whole organ transplants going? Well, the whole organ transplants still have an appreciable morbidity, depending on centers. And so most of us believe that it's not ethical to do that extra procedure unless you're doing a kidney transplant, because in addition to the morbidity of doing a pancreas transplant, you commit the patient for a lifetime of immunotherapy. If you are transplanting a patient who is also having a renal transplant, they are going to be on immunosuppression anyway. Now, the islets have been shown to work in very few cases. They are rejected to a greater extent than whole pancreases. And one of the major problems with islet transplantation is getting enough islets. It takes about 3 pancreases to transplant enough to completely reverse diabetes. What people are trying now is to put islets into little wiffle balls. Now they can get these wiffle balls down to a size where it'll be 1 islet per wiffle ball. About 20 cc's would be all that would need to be injected. And you can do this intra-abdominally. Now, the advantage of this wiffle ball is it doesn't allow immunoglobulin or lymphocytes in to destroy the islets. The problem so far is that these become crudted over with fibrin, so they don't last. So this is not a medical problem. This is a problem of surface physics. We need something like Teflon or Cephalon to coat these things. So this, I think, is a problem that can be overcome, and that this is the way to go in the future, because you don't need human islets. This would solve the problem. We've treated people with pork insulin for years, and pork insulin and human insulin differ by 1 amino acid, and they're comparably biologically active. And we have no shortage of donors of pig islets. So this would also solve that problem. Yes?
I wonder if you could comment on the role of ACE inhibitors or their cousins, ARBs. I attended an angioplasty review course for the boards coming up last week, and in 10 studies or more, they noted that ACE inhibitors or their cousins, ARBs, not only decrease the rate of death, but also heart attack, stroke, heart failure, diabetes, and renal failure with diabetes when ACE inhibitors were prescribed. Could you please comment on the presumed mechanism?
Well, these are related compounds. And the ACE inhibitors are approved by the Food and Drug Administration for treatment of early renal disease. When people are leaking just a little bit of protein in the urine, this is called microalbuminuria. It's one of the earliest signs that the kidneys have been affected by diabetes. Use of ACE inhibitors slows the progression, and this is independent of their effects to lower blood pressure. And I know many physicians who have diabetes who don't have microalbuminuria who take these agents prophylactically because they're very safe. Now, related to this are the effects of hypertension. I didn't go into this, but the UK PDS study that I mentioned also looked at the effect of tight control of hypertension on development of complications. And that actually had a much greater effect than controlling blood sugars. In fact, heart failure was reduced by 50%. And between the control group and the tight group, there was about a 10 millimeter mercury systolic, 5 diastolic difference. And they were not treating as vigorously back in those days as we are now. The current recommendation by the American Diabetes Association is to treat diabetic patients to a diastolic below 85. Any other questions? Yes.
Regarding this ACE inhibitors, you mentioned that there is even a prevent from overt diabetes. They mentioned that it's about 38% less diabetic compared to people who are not on ACE.
Well, ACE inhibitors have been shown to improve insulin sensitivity. Not as much as the thiazolidine dione class of drugs, not as much as metformin. And we're not quite sure of the mechanism. It may be related to the fact that they impair bradykinin degradation, and bradykinin has been shown to be an insulin sensitizer. So certainly ACE inhibitors versus other antihypertensives would have a big advantage. But I don't see using them in a practical sense to prevent getting diabetes or prevent deterioration in glycemic control. One of the things we've learned is about beta blockers in people with type 2 diabetes. It used to be a no-no in diabetic patients to use them, but now we know that diabetic patients get as much benefit from beta blockers with respect to heart failure as non-diabetic subjects. And there's one beta drug mixed as alpha and beta blocking effects, which seems to have preferential effects in that beta blockers cause a little bit of insulin resistance. They may abnormally affect lipids, and this drug doesn't have that effect. Yes?
Does alcohol have any independent effect on diabetes one way or the other?
Well, I majored in Latin and Greek in college, and of course we learned a lot about Aristotle. And he believed in moderation, the golden mean. Now, I think most studies in diabetics and non-diabetics have shown that in men, up to 2 glasses of wine a day, women, 1 glass of wine, reduces the risk for coronary heart disease. The same thing would apply to people with diabetes. Now, you have to be careful in overdoing this because alcohol inhibits gluconeogenesis. And in Dallas, Texas, the most frequent cause of emergency room visits for hypoglycemia is alcohol hypoglycemia. So alcohol can synergize with insulin or sulfonylureas to lower the blood glucose level, increase the risk of hypoglycemia. So that's what we worry about. Plus, if you drink too much alcohol, you might get an increase in your triglycerides. But in moderation, I think we all would say that it can be a good thing. Yes?
Doctor, there's been over the last 15 years a plethora of increased, I happen to be an obstetrician, in gestational diabetes. Is gestational diabetes a true type 2 diabetes A? It is one of the leading causes of stillbirth, which we have, also preeclampsia. Everyone seems to want to give these people insulin, but no one seems to want to give them any of the oral agents. Can you explain that to me?
Well, in answer to your first question, you're probably familiar with the old studies of O'Sullivan, who showed that there was a great probability of a woman who had gestational diabetes ultimately developing type 2 diabetes, especially if there was subsequent weight gain. Now, we use insulin because we're worried about teratogenic effects of pills. Insulin is not teratogenic. There is some data in the literature that sulfonylureas might be teratogenic. I'm not aware of any data on metformin, but the main reason we don't use pills is because of the fear of teratogenicity.
Dr. Gaskell was recently written about bone mass index and that includes incidence of diabetes. What about Dr. Gaskell's work, bone mass index?
Body mass index. Okay, body mass index, BMI. That is a surrogate for percent body fat. The gold standard for measuring body fat, percent body fat, is underwater weighing. And there's a very good correlation between body mass index and percent body fat. And body mass index is your weight in kilograms divided by the square of your height in centimeters. And normal is considered up to about 25. Between 25 and 30, the liberals say that this is overweight. Conservatives say that's obesity, but generally BMI of over 30 is considered obese. Now, there have been many epidemiologic studies looking at mortality, cardiovascular mortality, risk of developing diabetes as a function of BMI. And basically, it increases above a BMI of about 22, 23, even within that little range. The Healthy Nurses study has perhaps the best data because you've got tens of thousands of people in this study. And that study showed that even as the BMI rises over 22, you get increases. Now, to go from 22 to 25 isn't going to increase your risk a terrible amount. But it's a linear relationship. So, yes, that holds not just for risk for diabetes, but risk for coronary heart disease.
I have a related question, I guess, to that. The biggest challenge I've found in primary care is getting the people to lose the weight. And yet in your study, you were just so matter-of-factly got these people to lose 20 pounds and had a very impressive result. And I was impressed with that. Could you comment on that? Did you pick people who lost the weight and the ones who wouldn't just weren't in the study? Because it seems to be a very, very important thing to do, but it's a real challenge.
Okay. The data that I showed was from Dr. Henry, who's at the University of California. And this was an experiment where they recruited the volunteers to go on this diet, and I think this was an inpatient study, and the people got paid to do it. Now, I have the same problem that you do. Getting people to lose weight is terribly difficult. In the past, we weren't sure about whether reducing was going to help the diabetes and whether that was going to reduce complications. Now we can tell people, yes, if you lose weight, your diabetes will get better and you may not get complications. But the statistics on getting weight loss and having people keep it off are awful. There's a higher percentage cure of lung cancer with surgery than there is with us and obesity. Now, the people who have the greatest success are people like Weight Watchers. And recently we've had some additional help. You have a diet pill which can maybe help people to lose 15 pounds and keep it off over a 2-year period. Most people need to lose more than that. And then you have Xenical, the drug that inhibits the enzyme in the intestine that breaks down fat in the diet so that you sort of can have your cake and eat it. You will malabsorb a certain percentage. Now, the problem is, if you eat too much fat, you drip. And people have to wear diapers, and they get some cramps. So, although this would be a big help if people would take it and give them a negative feedback, it too doesn't produce a lot of weight loss. And not all studies have shown that it helps glycemic control. Depends on how much weight is lost. The most successful treatment of obesity is surgery, but this is only used for massive obesity. People with BMIs over 35 or over 30 and cardiovascular risk factors or diabetes. But that, I think this is one of the major public health problems in the United States. And you know, it's getting worse. The prevalence rates are going up, especially amongst adolescents. It's almost like an epidemic now amongst adolescents. I think the public health approach is the way to do this. Early in the schools, teach nutrition. Teach what's junk food, what's not junk food. Get young people into physical fitness programs, serious physical fitness programs, to teach them early on a healthy lifestyle. I think that will have perhaps major impact. Yes?
At the end of your talk, you mentioned a blood sensing device for sugar. Is that available? And if so, through what company?
These are not commercially available. They are in clinical trials, so you have to be in a clinical trial. One that I think is very near approval by the FDA requires a subcutaneous puncture, but it gives you continuous glucose recordings every 6 seconds, and it'll store it on a chip. Another one that was shown at the American Diabetes Association is called the GlucoWatch. It's just like a watch. You don't have to puncture anything. And it, too, will record the blood glucose levels.
And just a final question. How does that relate to mechanical devices, sort of artificial pancreas? Are those in development, or have people given up on those?
Well, the major drawback or limitation for these artificial pancreases has been the glucose sensor, because they can miniaturize the pump. You know what the Mini-Med pump looks like. It's pretty small. Now, what you want to do is close the loop. Measure the blood glucose, have that signal go to the pump, and if the blood glucose is going up, it pumps in more insulin. If the blood sugar is going down, less insulin. So if they take those two together, now what you need is an intravenous access for the insulin, or to put it into the peritoneum. So again, an artificial pancreas is going to be somewhat invasive. Yes?
I have a question about diet. My husband was a diabetic, and I was taught many years ago the exchange system for portioning meals and so forth. Now it seems there's a lot more carbohydrates, if just a lot of sugars are allowed, and just different things where, that was taboo.
Well, the recommended American Diabetes Association diet is pretty close to the American Heart Association diet. About 55% carbohydrate, 35% fat, low in your polyunsaturates. And what people have found is that some of the simple sugars, if they are used in the context of a regular meal, aren't too bad. Even having a Coke while you eat isn't terrible, is not something that you cannot do. Now, we're getting away from exchanges, and we're teaching people how to carbohydrate count, because the amount of insulin a person needs to cover a meal is directly proportional to the carbohydrate content. Now, it may differ from person to person. It may be 10 units, 1 unit for every gram in one person. It may be 0.8 for another person. But once you figure that out, you can teach the person how to count their carbohydrates and to teach them how to vary their insulin with what they're going to eat. Now, this mainly applies to type 1 patients who would be taking rapid-acting insulin before each meal. And we have a lot of type 2 patients who are on the same type of regimen. So that's where it is particularly useful to carbohydrate count, when you're taking insulin. If you're not taking insulin and the body is secreting its own insulin in relation to the meal, the most important thing, of course, is total calories, because most of our type 2 patients are obese. But the American Diabetes Association diet is very much like the American Heart Association diet, and it's better to have a higher carbohydrate content than fat. Okay, well, if there are no further questions, thank you very much again.
Thank you very much, Dr. Gerich. Before we break for the reception, if you would just wait a minute, John Dolan, who is on the Dolan Lecture Committee, has a presentation to make. And I would comment that Dr. Gerich is going to be at the reception and examining all the plates that you have. John?
Well, Doctor, before I present this, I just want to say I'll be at Weight Watchers the first thing in the morning. On behalf of my family and my mother, we'd like to present to you this check and thank you for the lecture and this plaque in memory of my father.
Oh,
thank you very much for your lecture.
Thank you very much. I really can't tell you how thrilled I am to have been invited here to give this lecture. Thank you.
Let's all go eat lightly. And please come back next year.